toi.
On commence tout de suite. Ok. Jérémy, on commence. Pierre, on commence maintenant?
You're the boss.
Ah,
Exactly.
à chaque fois. Ok, bah alors je vais faire la présentation en français après avoir souhaité la bienvenue à Katharina et ses collègues. Donc aujourd'hui, on a une présentation de Katharina Paul et de ses deux collègues, lesquels elle a publié plusieurs papiers, qui va porter sur la question de comment on donne de la valeur à la vaccination avec le cas autrichien. Et vous verrez que un des aspects qui est assez intéressant de ce qu'elle va nous présenter, en fait, c'est qu'elle a aussi un aspect de son travail qui se situe beaucoup en amont euh, de là où on travaille nous d'habitude, en sachant de se poser la question comment les gens qui conçoivent les vaccins se demandent si ça vaut la peine ou pas et ce que ça vaut. Donc avant même que les vaccins soient commercialisés. So, Katharina, you can share your PowerPoint if you can start. Hugo est revenu.
Yes, I'm back. Sorry.
Merci beaucoup pour l'invitation and for the nice introduction. I want to tell you a little bit about the project I've been working on, and my two team colleagues are also here, Dimitri Zhikarevich and Nora Hansel, who've also contributed substantially to some of the things I'll be telling you today. So the background to this is back in 2019, I was kind of going about my business, trying to get funding for my research on vaccination. And that was somewhat difficult as a political scientist because most people didn't really see how politics had anything to do with vaccination, and I constantly had to argue why that was an important thing to study. And then, of course, as we all know and remember, the pandemic came a year later, and then it became even more difficult to get funding because, everyone else had discovered the interest in it and also tried to get funding. But nonetheless, I submitted a grant application, which was kind of concerned with a very fundamental question, as Patrick was just saying, that why do people vaccinate, to begin with? Why is it good for many people? Why is it valuable? How did we even come to a situation where actually a majority of society supports vaccination in one way or another? And this sort of fundamental question, I wrote a grant application about it. And you know what? I didn't get the grant the first time around. So I waited another year and I submitted again, and then I got the grant. So this is why I'm here today. It could have gone very differently, right? But very happy that I can report some of our findings today. So what I'm going to do is walk you through the project design and the basic rationale, and then I'm going to report some findings, particularly from two kind of work packages, I suppose. Yep. All right. So when we submit articles to journals, people always ask us, why should we care about Austria? Why should anyone be interested in this tiny country of 8 million people? They don't have mandatory vaccination. It's, a very small country. What's the interest here? Well, of course, I'm a bit biased, but I think it's, tremendously interesting because Austria has actually a very extensive national immunization program. A lot of vaccines being offered free at the point of care, number of optional vaccines, or not optional, but vaccines that are paid out of pocket. And decision makers are constantly struggling with which new vaccines to introduce or not. And there's a lot going on at the moment. But at the same time, there's also significant vaccine hesitancy. So people vaccinating selectively or delaying vaccines, or just outright rejection, basically. And we see the sort of delaying or selective vaccination, particularly with respect to the measles vaccine, where people vaccinate much later than in the European average, and against the recommendation of the World Health Organization. And also with respect to the flu vaccine, Austria has a very low kind of vaccine uptake, even among healthcare workers, as we were just discussing a minute ago. But, this vaccine hesitancy is something historical and was always there. And we certainly know this from the Eurobarometer survey, also pre-COVID. But the other really interesting thing is, and I say this as a political scientist who's been studying vaccination, is the kind of political system in all of this, in which all of this is happening. So it's a federalist system, which means it's a decentralized political system where 9 federal states get to implement policy in whichever way they see fit. So funding is kind of split between federal states and the central government, but they can implement and design new instruments should they want to do so. But overall, there are no vaccine mandates, and there's also no incentives, no sanctions for not vaccinating, no reminder systems, and it's overall kind of a messy, fragmented system where much of the policymaking, I think, is kind of like muddling through. So just seeing what happens and, taking very incremental steps towards something, that, could sort of be a better vaccination system. So this decentralized, very fragmented system is sort of the context against which, much of my research is happening and designed. And also in the past, maybe it's worth mentioning, there were some pretty sort of controversial policy moments, such as with respect to vaccination against human papillomavirus about 10 or 12 years ago. So lots of discussions. So then how did the pandemic affect this picture and what happened there? As much as, we were happy to see new graffiti in Vienna. So on the top right, you see a picture of prominent graffiti that is basically the imperative version of the verb to vaccinate. And also decision makers finally came up with new ideas as to how to promote access and improve access, such as vaccination buses, large-scale vaccination centers in shopping centers, just churches even offering vaccines. Despite these attempts, basically, COVID vaccination efforts remained not as effective as they would have hoped, because of party politics, especially from the extreme right, also the spreading of conspiracy theories, and heavily politicized policy area, where the failure of individual politicians was framed, or where the failure of vaccine rollout was often framed as the failure of individual politicians or the government at the time. And much of this was also mixed up with kind of like an opposition to vaccine mandates. And interestingly, actually, very early on in the pandemic, way before there was talk of any vaccine, people immediately started talking about vaccine mandates and whether they would be justifiable in some way. So they kind of marked the discourse in very early on, but actually amounts to a policy failure because there was a vaccine mandate for a few months, but it was never implemented due to administrative difficulties. That was one of the reasons. And also because, political costs associated with the mandate. So, and at the time was fortunate to work with colleagues in context of the Austrian Corona Panel project, where we did a cross-sectional survey and found that people also kind of lacked a sense of community. So not only did they have limited motivation as to, get vaccinated for the individual benefit, but they also didn't think so much about the sense of community. And, one of the C's, I guess, in the famous 5C model that social psychologists talk about. So the vaccination system didn't get overhauled in any way with COVID. And it's more sort of a story where, many of the issues that the vaccination system has got exacerbated, including vaccine hesitancy. So now on to the Valuing Vaccination project that I want to talk a little bit today. But this was for the context and, the things that still kind of mark the discourse nowadays. So when you think about this, media coverage around the pandemic on vaccination, I found that vaccine hesitancy was very heavily moralized. So people holding the wrong values, people being stupid or crazy. So vaccine hesitancy being reduced to either, low scientific literacy, or ignorance, or people just, being victims of conspiracy theories. And there wasn't really so much reflection on, how to improve access or how to improve the system at all. And I kind of wanted to move away from this idea that people were just holding the wrong values and think about how, we can open up this kind of discursive space and think about how different groups actually come to value vaccines. So valuing as a verb rather than as a noun, and how different groups perceive of the value of vaccines and how they come to do so. And the idea was really then to kind of map this sort of idea of valuing onto state-society relationships, because I believe that, the way we observe things, the way that people perceive the way that people perceive of vaccination tells us a lot about state-society relationships in different countries, different states. So this valuing approach we sort of called the multi-sided policy valuography. And in this framework, we label low vaccine uptake as a wicked problem. Wicked problem is a concept that planners developed in the 1970s when talking about social policy problems at the time and urban planning issues, homelessness, for example. And here, wicked problem framings, I think, make sense because it's a similar problem. It's unique, it seems irresolvable, because actors have very different understandings of what the problem actually is and why we have low vaccine uptake. So it's a unique problem. It's uniquely contested as well by different actors, and there's a lot of scientific uncertainty. So these are also generally features that mark wicked problems. And against this sort of uncertainty, contestation of values, we wanted to develop a symmetrical approach where we wanted to talk about not only about those who oppose vaccines, but also about pro-vaccine attitudes. And some of our academic friends, like Sam van der Slot, have, of course, also, really nicely examined pro-vaccine activism in other countries as well. So with this symmetrical approach, the idea was to not talk about values and conflicts, but talk about valuations and to look at kind of more neutrally at what happens at perceptions and how people arrive at those perceptions rather than only fixed attitudes. And sort of this idea of valuation practices is then informed by the idea that it's not conflicting values, but conflicting valuation practices. And here we draw on the work of Isabelle Dusauge and her colleagues. And here's a fun fact. This is where Jeremy and I think, first met, maybe something like 12, 13 years ago. And we talked about valuation practices there as well, I think. So what are these valuations? They are, as Boltanski and Thévenot say, practices of assigning worth to something, to social, to physical phenomena. It's also a way of making sense of things, I guess. And these valuations also mean that they become consolidated, they become institutionalized over time. They maybe become part of a regime of valuation, as some say, but they're never quite settled. So the way we hold, so the kind of value we ascribe to things is never stable. It changes, it gets re-problematized at critical moments. For example, when there's a vaccine injury, right? This shakes up kind of discussions of the value of vaccine. Or when new vaccines arrive, or when new platforms for vaccines are developed, that kind of shakes up sort of established valuations of vaccination. When we think about valuations, maybe to make it a bit more clear, these are things that are not just mental states, they're not just feelings or cognitive states, but they're actually when we do things. So think about wine or chocolate or grading or tasks at work or prioritizing manuscripts or reviewing manuscripts or grading student work, these kinds of things. We're constantly sort of engaging in valuations. And so people also do this with vaccines that hold such a central place in contemporary society, but they do this from different perspectives. So in this multi-sided policy valuography, we basically ask what value do different actor groups assign to vaccination? Also, how do they do this? How can we observe this? And as one does in these large projects, we divide this up in sort of 5 sites, as we call them, or work packages. One is vaccination policy programs, basically, or the National Immunization Program. Second is digital spaces. Third is pharmaceutical industry. Fourth is research and development on vaccines. And the fifth is care or primary care. And we use different methods across these different sub-projects. So I did a lot of elite interviews with decision makers in the past and with scientists. Nora Hansel, who's also here today, has done a lot of interviews with parents, over 30 interviews with parents, also interviews with doctors, and she did participant observations of about 200 hours in doctors' offices. So 2 of them kind of, one of them sort of a large public office, one of them a private doctor's office, and the third one also private, and sort of one that focuses on complementary and alternative medicine. So we tried to get kind of like a, an interesting sample out of that. And we did content analysis of, particularly of an online forum, and I'll say a few words about this maybe in a second. And maybe to give you an overview, or maybe a better idea of what these valuations can be like. So if you look at policy programs, I think one of the main things where we can see evaluation happening is cost effectiveness. So this value that guides much of vaccination policymaking emerges from health economics, has a long history, but this is really a central valuation principle that happens, or valuation practice that happens in health in policymaking. Industry actors, of course, think about return on investment when they think about how to, invest in vaccines. They also think about prestige or reputational value when they develop certain vaccines. And with parents, for example, we see that they value individual vaccines differently. So some of them being more important to them as individual families, others maybe more important to society at large. And so across these different sites with different groups, you really see different value principles guiding people's actions as well. All right, I want to zoom in on two of these sites, and a disclaimer is also that with respect to the industry, it's something that we wanted to do, look at, for example, how industry actors price vaccines, but it's something that's almost impossible to do basically outside of archival research. So we really do not have direct access to this, but we'll show you a little bit about how these kind of value logics play out in research and development on vaccines. So, as many will know, research and development on vaccines is a very long, very complex process. Requires substantial resources, of course, specialized expertise, and a lot of collaboration between different actors, including regulators, actually. And so this is also why, in view of, the vaccines, not the vaccines we do have, but also the vaccines we don't have, think about malaria, TB, etc., although there's some progress. But then there's not only a failure of the market, as some have said, but maybe also a failure of coordination between these different actors. And here's where valuations actually are important in connecting actors. So what we find in these interviews with scientists here in Austria, including some who work for biotechs or those who now work for regulators, is obviously, quite sort of a tight networks in Austria. So in these interviews, we find that altogether there's sort of this overarching concern of making vaccines investable. And this happens very early on in the process. This may not be so surprising for those of us, observing kind of political economy of pharmaceuticals, but it's really in the preclinical phase, very, very early on, that scientists, researchers already have to think about, could this be of profitable value at some point? How do we sell this to pharmaceutical companies? Because it's only them who can fund clinical trials because they're too expensive for universities, for startups, etc. So this sort of, happens in the context of contemporary political economic structures where the state has, plays less of a role than they used to do in research and development. And in these interviews, which were done by Anna Pichelsdorfer and myself, so Anna is now in a different profession. She works for a funding agency, but she did many of these interviews. And Dimitri is here today. So in these interviews, we find basically 5 concrete practices of evaluation. So again, these are things that people do and people can express. They're not things we assign to them as mental states. So maybe 2 things. So one is a very particular practice where, once scientists have made some progress with a particular development, they actually go and get scientific advice. This is like a very heavily regulated moment, but it's a form of interaction between scientists on the one hand and regulators on the other hand. So scientists or startups make a little portfolio and, show the vaccine candidate that they're working on, and then they get some kind of feedback from regulators. And here they can see sort of, what they need to do to reduce risk or, what to do further on. And so these sorts of moments are key to, and they really shape vaccine development in very important ways. Another example is the concept of unmet needs, which is generally something that's important in pharmaceutical development, of course, but it's really, these are one of the key evaluations that people use in choosing what to invest in and what not to invest in. And I just want to give you 3 examples of citations, quotes from interviews. One by a startup founder, the second one is by a technology transfer office at a university, and the third one is, again, by a scientist at a startup. I'm just going to let you read those. Okay, so I think what we see here is people talk a lot about risk and about value and about the promise of vaccines and how they sort of, have to sort of calculate already and assess in advance and anticipate a lot of this. So a lot of this is speculative, anticipatory, but it definitely shows that there's sort of this ongoing concern of making something investable for a company, for a pharmaceutical company to take this over, basically. So this risk minimization and value maximization is really a sort of an ongoing concern in vaccine research and development. I now want to give you examples from a second site, as it were, and those evaluations in primary care that Nora has looked at. I've already mentioned the ethnographic observations and interviews, and the online analysis. Maybe a couple of words about this online parents forum we thought was quite interesting. What we saw there is that people like to put anecdotal evidence and scientific evidence or formal evidence in conjunction with one another and put it in very symmetrical ways. Like, your own experience is worth just as much as like some key reference by the Robert Koch Institute in Germany. So, and people feel sort of more legitimated to do this in an online form. I think they feel, sort of ashamed of doing this in a doctor's office, but they feel very comfortable in doing this amongst themselves. So online forums, a bit like playgrounds maybe, and then more anonymous, so sort of a safe space where people can exchange ideas and also affirm each other's decisions actually to some extent. And the other thing that parents really do on these forums is they develop what we call navigational capital. So in this kind of, messy system that I described earlier, or at least fragmented system, parents have to really ask each other, how do you get this vaccine? Is it free or isn't it free? Do I have to buy it at the pharmacy first and take it to the doctor's office? So to discuss a lot of specifics of the political system to develop this kind of navigational capital and being able to also even deliberate on future vaccination decisions. And Nora, in her PhD thesis, has some way more in-depth insights into this. And I'm just going to zoom in into one of the outcomes of this sub-project, where Nora is basically observing doctors and parents in interaction. And so, parents come to a doctor's office and either the doctor or the parents, it's usually the doctor or the receptionist that raises the question of vaccination. So they could say something like, today we're going to have the measles vaccines. Any questions? Or they don't add any questions, right? So very different ways, as we know, to communicate these things. And what Nora is looking at is sort of the situations in which parents and doctors kind of negotiate in interaction what the risk is. And they establish something that is called risk relationships. And here again, we're less interested in what the outcome is, or whether people vaccinate their children or not, but how they arrive at the decision and what kind of evaluations, what kind of concerns and perceptions feed into this decision. And unsurprisingly, risk is sort of the key reference point for people, a key concept. And there's a lot of cultural aspects to that. So people feel that risk is individual, or risk is, greater elsewhere in other countries. And they sort of engage in sort of culturally idiosyncratic risk minimization practices as well. And the three exemplary situations that maybe resonate with some of you studying other countries, we hope, are basically, one is prioritizing vaccines. So within the scheme, within the recommendations of the NITAG, of the National Immunization Technical Advisory Group, parents often negotiate which vaccine to take next and try to, switch up the sequence of things. They also negotiate the number of vaccines per appointment. Parents don't like to get more than one vaccine per appointment. They think the child isn't ready for that kind of, immune training. And the third typical situation is where parents kind of tinker with the national immunization schedule. So they say, oh, I'd rather wait another 6 months, or, when the child is in daycare and, my kid isn't ready yet, these sorts of things. Or vaccinating selectively. And this is definitely a big deal. And when you think about new vaccines such as the RSV vaccine, etc., these things can become very tricky when people vaccinate so selectively. So with these three exemplary situations, I'd be curious to how that works out in other countries as well. And the other thing about risk work as a sociological concept, what it really allows us to do is to highlight how much work goes into vaccination. So the work that mothers do, it's a very gendered kind of labor that people engage in. Women as health navigators, as they've been called in health sociology. They do a lot of this risk relationship and risk work. And doctors as well. I mean, it's hard work that they do, or nurses and receptionists, it's hard work that they do in establishing and negotiating these risk relationships. So this is kind of what this concept allows us to do, I think, highlighting the work and highlighting the invisible work. And maybe also just a couple of examples of quotes from this work package. I'm going to give you a few seconds to look at these. These are all from parents. All right. So what we see here again is that people value things in different ways. You know, what is the value of the risk and the benefit of the vaccination, and very idiosyncratic ways of establishing risks and benefits. And for example, what we see here, this is not so much about, you know, conflict of values. I think all parents want to protect their child, but it's a question, you know, that value is expressed in, you know, wanting to protect the child against a vaccine, or wanting to protect the child against side effects or infection itself. So that value just plays out very differently in the valuation practice that parents engage in. This is kind of what I'm trying to show with this. And again, I think what we see here is actually, so we see also in the material that Nora has collected, is sort of this lack of community or sense of community is not great in informing vaccination decisions. And then I want to show you a final sort of sub-project, because when we look at valuations, our central assumption is that basically when people experience vaccination, when people evaluate vaccinations, they're also simultaneously evaluating how policies are made about them and how they're governed. So how they're developed, how they're regulated, the political system in which they're administered, and the programs and the decisions, and how these decisions are made. So we kind of tested this conceptual assumption in a way in this sub-project on vaccine mandates, where we interviewed parents and doctors about their perception of mandatory vaccination. And we find here that people have actually very nuanced positions with respect to mandatory vaccination. This is selective COVID-19 vaccination, a mandate. And so they value policies in specific ways. There's a political value to a mandate, but there's also political cost to a mandate in terms of polarization. They value mandates in epidemiological terms. So if the shared goal is the eradication of a disease, then I think a mandate is good, but not with other diseases where you can't actually eliminate it. They also value mandates in terms of what they can do for the system, whether they make the system easier so that parents don't have to think about their choices all the time. And they also express a sense of, you know, that it's maybe an ethical choice to introduce a value, or in fact not to. But the ideal that people express, both doctors and parents, is basically a free decision, but an informed decision with more support and more education, more information, and maybe also a more proactive state in guiding people through this kind of, you know, complex system. So this is for the vaccine mandates specifically, which I thought it might be interesting. So maybe to conclude here, as far as valuation practices are concerned, we can see that these help connect and coordinate actors, and also allows for some kind of compromise, and a collective perception of what makes vaccines important and good, or at least good enough. But these valuation practices are iterative, they're ambiguous, and they're never, of course, settled. And they also happen in interactions, and across these different sites, actors connect in different ways. So these sites aren't really separate, right? But they're sort of methodological statements. We also see that valuations of vaccinations are tightly linked to valuations of governance. So, for example, we see that valuations happen in governance, right? So when decision makers talk about cost effectiveness, valuations also happen for governance, also happen through governance. For example, when people determine the right of patients to receive compensation for vaccine and injuries, that's also a form of valuation that happens in courts, which is also something we're looking at the moment. And we see that this valuation approach is actually really useful for looking at the kind of micro level interactions that happen in doctors' offices to explore how people arrive at decisions. And then maybe specifically this kind of risk work perspective is useful for systems that demand so much work of parents and of doctors. And we're currently looking through all our data more systematically to develop more conceptual arguments to this effect. But this is sort of an interim overview about the kind of compromises that evaluations allow, but also frictions, of course, that continue to occur. And maybe just sort of a preview of what we're working on now is we want to work more on NITAGs, on compositions and concerns that they share. And Jeremy and us will be talking in a couple of weeks, I think, about this. I'd also recommend you look at this lovely presentation or visualization that Nora did on how parents value individual vaccines. It's an interactive thing where you can click on different quotes and examples. I really recommend it. And we're also working with my colleague Christian Haddad here at the University of Vienna, on what vaccination means in an era of antimicrobial resistance and how vaccines are valued increasingly also in terms of planetary health. So you can see we're going different directions with this project, but it's really an honor to be able to talk to such an expert audience about at least some of these findings. Thank you.
Thank you very much for your presentation, Katharina. It was very interesting. So all participants feel free to raise virtually your hand, and I will let you ask your question. I will begin with a few ones. As I said before, one of the very interesting aspects of your work is that we, thanks to your work, we can ask questions such like why some vaccines have never been designed or marketed, because usually we only work on vaccines which are already available on the market. You told us that the Austrian context is quite specific, with 9 regions, and each region implements the vaccination policy how it in its own way. So I guess that there are differences in vaccination coverage rate between regions. But regarding the part of your work when you study how scientists and those who conceive vaccines value or them, I guess there is no specificity to the Austrian context, and I would like just to ask you a few questions about this context. First, and maybe it's a question for Nora, because about the observation of consultations, you talk about parents and then you talk about mothers. So I know that in the French context, and it's not specific to France, most of the time, mothers are the one parent who is in charge of all health issues regarding children and especially vaccination issues. So I would like to know when you observe consultations, if you observe the parents with both parents talking, or only mothers, or mothers talking more than fathers. You can answer now if you want.
Nora, do you want to?
Thank you. Thank you for the question. Yeah, actually, fathers were very present, much more present than I anticipated. But even in cases where fathers were present, still the decision-making power somehow ended up being more on the side of the mother, actually. So there was actually even an incident where the father called the mother who wasn't present during the consultation to ask her permission for a vaccination that wasn't planned that day, but the doctor initiated. So it was very very diverse in terms of fathers being present, not present. Also, we see somehow a change in terms of the policy for childcare leave after birth, where fathers are more present as well in that time, because they actually can take the time off. And somehow this transition between the mother is the one accompanying or the father is the one accompanying also has to be managed. So there is even more coordination work going on between the parents, as is actually visible in the consultations. But also the interviews were very like giving me more details in that regard. So I did also interview fathers, but it is a smaller part of the sample as mothers are.
Okay, thank you. So regarding these consultations, I remember a few years ago I was interviewed by I think a Swedish journalist, and he was very surprised because apparently in Scandinavian countries, people frequently decide to vaccinate for protecting the community. While in France, typically, most of the time, people choose to vaccinate for protecting themselves, not the community. And there is supposedly a kind of cultural opposition between Scandinavian countries and Latin countries. And I would like to know, where is Austria from this point of view? Do Austrian people vaccinate? Do they take into account the interest of the community, or just their own interest?
Well, I think that's a very binary way of putting it. I think what we saw. So here, I think it's really important to differentiate between childhood vaccination and COVID-19 vaccination and flu vaccination, so seasonal vaccinations. I think these are sort of very different motivations behind them, and it's a bit difficult to monitor them. With COVID vaccination, actually, we saw early on that people's decision making was very much influenced by their social environment and discussions they had at work and friends and so on. So there was a sense of community, but not sort of with the sort of, the abstract society at large, but more like, my grandparents, parents, and so on, vulnerable populations and so on. And people also give sort of socially desirable answers in those contexts, right? So it's a little bit tricky, I think, to measure that. With respect to childhood vaccines, there is, Nora, do you want to say anything about your data? No?
Yeah, I can jump in on that. So there is the main question that parents are asking themselves is always how to protect their child and how to protect it best. So the community takes kind of a backseat here, but it's different for different vaccines. For example, the polio vaccine, there is this like societal value that parents associate with it. And that is also kind of, it's part of a combined vaccine. So it's like not a decision they take just for the COVID vaccine, for the polio vaccine. But it's valued in that sense. So the community also plays a part, but it's a minor part compared to the individual protection. I would put it like that.
Absolutely, yeah.
Yeah.
Okay, thank you. And one last question. So it's another maybe tricky question. You quoted a parent who said the cost-benefit calculation doesn't work for me. So he was obviously trying to explain why he decided not to, or she decided not to vaccinate her child. And according to you, to what extent do parents really make a cost-benefit calculation, or to what extent do they feel the need to express their choice in this legitimate way? Because we have a lot of works that shows that cost-benefit, many parents do not really understand what is cost-benefit calculation, but they frequently believe that it is a legitimate way to frame their choice. So do you?
I like that. That's a great way of putting it. I think they're looking for ways to legitimate their choice, right? And parenting has become so much about making choices, making the right choices from, the timing of the vaccination to choosing the right schools. And informed, by some degree of scientific literacy in Austria, and informed by, some appeals to solidarity, etc., people do look for the kind of, draw on these, different repertoires in making decisions. And one of them is, well, this is my life. I don't travel. My kid doesn't go to school yet. So, this is the way I look at things. So I do think these considerations, there are somewhat, economists would say some kind of, rational calculations going on. And social psychologists also think that, right? right? That there's some calculation happening there, but never independent of the social context in which this family is, of course, experiencing life in society, basically. But I like your way of putting it, this legitimating a choice with, referencing to cost benefits. Yeah.
Thank you. Jeremy?
Yes. Thank you so much for this presentation. I think this is a very ambitious project, and you've done already so much in it. And I really think that you spoke about the difficulty of getting funding for basically research that tries to present an approach that moves a bit away from basically the main understandings of both vaccine hesitancy and policy making, where you have a strict delimitation between what is basically science on the one hand and society on the other, and what is like the correct way of making decisions and incorrect way of making decisions. And I think the fact that you entered through the framework of valuation, I think it's really very it's very powerful, and it opens up so many things. I like when we talked about it, yes, 12 years ago, something like that, which makes us sound older than I mean, hopefully older than we actually are. It's true that I hadn't seen exactly how much we could transfer this to basically individual decision making, or if we don't want to say individual, at least like ordinary decision making. And hearing you, I think it's the first time I really heard this, because I read your papers on the complexity of decision making using that. But it's true that the framing through the valuation framework, I thought it was maybe a bit secondary in there. And anyway, it didn't imprint my brain. And right now I'm seeing it. It works because it reminds us that when people make decisions about vaccination, it's not just calculation between cost benefit analysis, but there are all these different things. And I especially like the way that you reframed it through processes rather than basically what people think. It's how people combine thinking and deciding with people, etc., etc. So my first comment is the first thing I'm going to say is going to be a comment, and then there will be a question. My comment is that I think this is really in line with a lot of work that is emerging in the field of basically attitudes to science. And there's a particularly interesting paper that came out, I think, a couple of years ago by Gil Eyal and his team. You probably know the paper, What is Trust, or something like What is Trust the Name of, where they really shift the focus from, trust in science as basically a property of someone who like something that people think, but rather turn the attention towards, trust making, trust processes, and how different understanding of what science are not just ideas about what science is, but more how people work with the information they have in mind. So I was wondering so I'm transforming it into a question, like, is it something that you thought about, and how do you do you create an interface with these type of work on basically trust as a process, understanding science as a process, etc., etc. So is there something you could tell us about it? And the second one is going to be a bit more of a traditional question. I was really interested in something that's very like minor in your presentation, but it tickled exactly the right the right part in my brains. It's when you were talking about the non-application of the COVID mandate in Austria. This is something this is basically one of my obsessions, is how, like, in France we have the practice of voting laws and not applying them, because we really like the symbolic nature of saying, like, this is important. If something is important, we need a law to say the state says it's important. But historically, that's what we did with mandates. We voted laws to make vaccination mandatory just after the Second World War. They were never applied. There was no décret d'application. So they were literally laws that didn't have the second aspect of the law that says, now you must abide by the law. They say, we said it's a law, now deal with it. And then when we re-voted laws after the Second World War, there were the décret d'application, but the ministry didn't say this is how you should implement it. They said all towns should make sure that children are vaccinated, but we're not going to check. I'm not going to tell you how to do so. Just like deal with it anyway. And I think like so much of valuing is performative, is discursive, is something around there, and there's a lack of understanding of both the administrative aspects of it and all the barriers that can come with it, and also often the fact that and often the yes, the complexity of what it means of forcing people to do that, especially in a context of COVID-19, where the situation evolves so fast. So, for instance, in France, we created a law saying people should be vaccinated, otherwise they can't go to hospital, they can't go to lots of different places. We voted in the summer of 2021, but then we make it stronger. Like people should be vaccinated. They can't just present a negative COVID test. They have to be vaccinated. So you voted in January 2021, and then it's abrogated at the end of February 2021, a month after, with discussions about abrogation arising at the moment when discussion of extension where the extension is being voted, which is something quite bonkers. Anyway, can you tell me more about this COVID mandate in Austria and how and why it came to be and not to be at the same time, please? Thank you so much.
Yeah, thanks, Jeremy. That's a really great and helpful comments on how to I think push some of those elements further that we're talking about with respect to the mandates. Yeah, so I mean, so as I was saying earlier, that sort of topic of mandates was sort of there from the very beginning, and I think it was maybe strategically a bit of a mistake, but sort of it emerged very in week 2 basically of the official pandemic. People talk about potential mandates and all these series of talks and interviews about mandates and so on. And there was always very strong advice by social scientists and social psychologists, such as Robert Böhm, who's a rock star in social psychology with respect to vaccine mandates. And he was on one of the advisory committees also to the government advising against mandates for the usual reasons of reluctance and so on. Sorry, what's the word? Not reluctance, but so people reactance, right? So people
reactance,
reactance. So, and basically the way they framed it, so we had a bunch of ministers of health during the pandemic because they kept resigning due to burnout, basically. And the way they framed this mandate was a very sudden thing, actually came as a surprise to many of us, I think. And they said it's this is the last option. People are not getting vaccinated enough. So this is what we have to do. So they presented it as inevitable. It's not something they decided, but it is something they have to decide, not like as a political decision, but it's something that was just decided by the public, basically. And they passed the legislation, and the timeline, similar to the one in France, I think at least over 4 months, I think, before they, basically took the law back. And it was never implemented because the idea would have been to introduce financial sanctions. So mandate's all about, what happens if you don't comply. So people were to be fined with some amount, maybe 200 euros, I don't know. And basically, because they are not allowed to link certain data registries in Austria, they couldn't actually implement it. So this also opens up a whole other chapter about data politics in Austria, which is so interesting because they collect a lot of data, but they don't make the data mobile to improve governance or do anything with it. So they couldn't implement it, but then they said, well, it's not that we can't implement it, but also there's Omicron and it's pointless to do it anyway. But this had enormous, I think, political costs with respect to the reputation of the vaccination program. So I'm sure you didn't ask for my personal opinion, but that was essentially my personal opinion that I gave. But these policy failures are so fascinating. And it's also fascinating, of course, what happens in the context of this very, quick political decision making during pandemic. It's exceptional, right? So, but it's completely off the table now, by the way. It's completely off the table, this topic, or this, policy instrument. And I'm not sure that answers your questions about the mandates, the very short timeline. It was so short-lived, yeah. Yes, and I remember, so I had a small baby at the time, and I was on parental leave, and I thought, no, now I have to work on mandates. And fortunately, it was short-lived, so I didn't have much to say about it after all. But I thought this is another chapter. Like, I can't believe this. Okay, sorry, that was a bit too casual, maybe. And with respect to the work on trust and the work of Gilayal, we've read a lot of his work actually. Dimitri, did you want to say anything about this, maybe? How that ties up with our work?
Yeah, I maybe could. Sorry, I'm gonna appear now. Hi. So yeah, we did read a bit of Eyal, mainly his work on the sociology of expertise, which was this big theoretical project. There are many things to take from there, but one important thing which we always had in mind in the work in this project even if, it may be not very explicit in some of the papers, is this idea of expertise as a network. And as expertise is something that is not reducible to the people who kind of carry it and are legitimated to do so, the experts. So that's one thing. And then the thing in trust that was mentioned, this paper, I think it's really part of this larger theoretical agenda, which basically says that trust is an effect of this ongoing relationship between experts and non-experts, which must be contextualized very thoroughly and kind of addressed from this point of view of expertise being much more than just the experts and their credentials. So I think that's the kind of the general thrust here.
Thanks, Dimitri. Thanks.
Okay, so we have a question which is still about mandates in the chat. The National Institute of Cancer in France. The National Institute of Cancer director has spoken about a possible mandatory HPV vaccination to be implemented. The mandatory vaccinations in France for the 0 to 2 years old children is linked to the school or day nursery access. Have you ever discussed the juridical context to make the vaccination mandatory in Austria?
Specifically about HPV vaccination? Yeah, so that was definitely never on the table because that vaccine was discussed so controversially when it came onto the market, and it was on the market to be paid out of pocket for young people even at the time. So between 2012 and 2000. When was it? In 2014, when it was introduced into the National Childhood Immunization Program. And they really had to, this being a Catholic and fairly conservative country, it was a lot of sort of, maneuvering of these issues of sexuality and cancer and these very complicated links. Or actually not that complicated if you just explain it to people, but they were hesitant to explain to people and young people and kids, how you basically get HPV and why that causes cancer. And I think there's still some hesitancy in talking about these things. There's now some school-based vaccination, at least. So this is one of the few vaccines that are actually or can be administered in some schools, not in others. So these are only elementary schools and then not in middle school anymore, although that's, the more suitable population. But at least that's one of the things that have been introduced in schools, and also a recent campaign for young people up until the age of 30 can get it for free. So at least some success, I think. And interestingly, also some social movements behind that actually in Austria. Particularly in Vienna, which is, quarter of the population lives in Vienna. So that's why it's significant then. So quite a social movement of young people and students behind pushing this vaccination. But no mandate, no.
Still regarding mandate, I speak under the control of other participants, but last month we had a lecture by Philip Schmidt who talked about also about the fact that the risk that mandatory vaccination may lead to vaccination reluctance. But in fact, he was not convinced, but he considers that the risk of reluctance was not so high, and that there were many, not many, but several advantages of mandates, especially the fact that through mandates you redistribute. You make a redistribution of responsibilities.
Yeah. I think so. I think in Germany they have good data to monitor our attitudes. We don't really have that here at the moment as much, and so I think they can say very nuanced things about risks and values of vaccination mandates. I think it's really interesting. It's politically off the table. I think from a research perspective, it's not off the table, but and certainly with the next pandemic and so on and so forth. But in terms of what we know, these are very dynamic attitudes as well, right? And distributing responsibility and also the risk across the population is definitely something that could be appealed to. It's interesting. I'll look up the new work that they have on this topic and spread the word here locally.
Okay, is there another question in the chat?
Oh, maybe I can add something. Sorry. What's actually interesting is that some people still believe that there are vaccine mandates, because what they used to do, so they get this mother-child health pass, which is like a little yellow booklet, And inside the yellow booklet, there's a small yellow booklet, which is the vaccination pass, which now is electronic, only in part, of course. But so in this yellow booklet, it's stapled into the mother-child health pass. So a lot of people thought, oh, if it's in there, it's mandatory, because otherwise I don't get my child care benefits that people get while they're on parental leave. So the perception was for a long time that it's actually mandatory. That some of them are mandatory. It's also definitely a matter of framing it, how pediatricians frame the issue of vaccination. And yeah, I have many personal opinions about this, but again, not now.
Jeremy again?
Oh, if no one else wants to ask a question with it. Other question on the valuation framework, and this question of like basically the level or like what you are studying. It seems to me like it's quite all-encompassing. You're both interested in the processes that lead to vaccination science being produced and vaccines being produced and recommended, political decision making, implementation, and basically public, the policy target, etc., etc. I was wondering how, like, you construct this interaction and what you can say right now about what the valuation framework, what it helps you to do in terms of this articulation, because it seems to me it speaks to one of the crucial issues we have right now in the literature in vaccination, but I want to say the literature in social science in general is that usually people are interested in production of knowledge and technologies are interested in production of knowledge and technologies. People are interested in who are interested in the trajectory of political problems or political disinformation, they're interested in this. And everyone is interested in their own specific thing. But the work of articulating is either done by armchair sociologists who just write an enormous book about what society is in general, and we're lacking like empirically grounded work about concretely how do we articulate this using specific methods that ask things to data. So I'd like to hear you on that. It's a very difficult question, I realize that, but yeah, I'm asking it anyway.
Yeah, great. I'm glad they didn't ask me that during my grant interview. But it's very much on point because it may be too all-encompassing and not too ambitious, but maybe these things you have this ambition to develop something that explains everything or is able to describe everything. And the thing is, once you get into this valuation studies literature, you see it everywhere, right? So it's like sort of so enlightening. And then if as a very interdisciplinary Austrian social scientist on vaccination, when you read these French things in English, mind you, when you read, these French writings on valuation studies, it's all very intimidating and impressive. And I think I'm trying to develop sort of an approach where we can use these terms a bit more pragmatically and practically and empirically. I think that's my aim here, really to introduce them into a methodological language that we can use across disciplines, or across different disciplines at least, in a way to articulate things less conflictually, I think, also when we speak to people affected by vaccination decisions, for example. And I find that actually works. I've, given talks to doctors at trainings and, and sort of general public, science to public kind of events using this valuation language. And it sort of, resonates with people actually, because they recognize themselves in many of these things in the everyday work. But I see the risk of it being too all-encompassing in a way. But nonetheless, I think it's my ambition to at least connect some of these different spheres. But it's not always a very welcome role in some of the disciplines that are a bit more territorial, if you know what I mean. So yeah, it's definitely something I think I'm grappling with at times. Yeah. And also something to say about the project team. It's super interdisciplinary. So Nora is a much better political scientist than I am. I think so. At this point, I'm super interdisciplinary at this point. I do a bit of STS, medical sociology, policy analysis. Dimitri is an economic sociologist. So we've had different people also working on the project with different interests. And it's, I find that actually, particularly the valuation language helps bring these people together because it's something to recognize in practices. Yeah, and it's easy to get people interested in practices because we all do things, and giving examples, I think, helps. So part of the appeal of the valuation studies is maybe the bridging of different languages and disciplines. And then the next step is to use it more pragmatically and with more courage and with more pragmatism. Yeah.
Or the
I,
opposite, just
sorry.
be the armchair social scientist who writes the big book about, what society is, and then you don't have to, do all of that messy work of having to deal with just, data and people, etc., etc. Just
Yeah,
write the
but I'm
book
pretty
saying,
hands-on. My
yeah, I
armchair
know.
is not good enough for a book like this,
You
first.
need to buy a new one.
And I'm very hands-on with the empirical stuff, much like
Yeah,
you
of course.
to me. So, but let's talk about a joint book project. We
Oh,
both
oh.
share an armchair.
And I have another question from the chat. Do you plan to have the feedback of of associations of immunocompromised patients on vaccinations value?
That's a really good point. Yeah. It's interesting, because I've actually I know quite a bunch of people who were affected by this. There are not many patients organizations here, but we should look some of that up. That's a specific angle, but an important angle, particularly because it was people realized this more during the pandemic, right? That this is an issue. Some people cannot get vaccinated. It's really interesting idea. Nora, I think we should explore this and
Yeah,
see.
may I jump in for a second? So there were actually some children who were born prematurely in the observations, and also parents of these children in the interviews, which was, of course, not the same, but there the valuations get even more difficult and conflicting between protecting the child when to give the vaccine, or how to also protect the child from side effects. So these parents were very, doing the risk benefit calculation, so to say. But yeah, it's a small part of the sample, but it's a bit of data on that. But I would love to also include associations, but it's hard in Austria. There is one that is very active at the moment for children, but they also focus on mental health and all these topics. So vaccination is just a part of that, of course.
Okay, is there another question? Jeremy, did you forget to?
No, I just re-raised it. But if anyone, we might be a bit tired of hearing Jeremy asking fake questions and having one small question at the end of a just big comment. Does anyone want to ask a question before me? Please. Because if you leave me the floor, I'm going to ask questions for at least the next 45 minutes. So please, like.
No, not.
Okay, never mind. So I'll ask my question. It's on a similar note to the one that has been put forward, the issue of basically touching upon patients. How big is the issue of long COVID in Austria? And has it been early on, or is it something that happens like that gained prominence later? In France, basically, there was almost zero talk of long COVID, except amongst very specialists of infectious diseases, etc., who were saying like, why aren't we talking about this? And still to this day, like long COVID associations, they're very minor. They fight, but as much as they can. There is some funding for research on that, but there is no political traction around that, and they have great difficulty of making this real in society in some ways. And I was wondering what's if it were the case in Austria, and how much these issues around long COVID like intertwine with controversies over the COVID-19 vaccine, because at some points, for instance, lots of people were saying the long COVID is caused by the vaccines themselves. Of course, epidemiological data tended to show the opposite. What's up with long COVID in Austria?
Yeah, thanks, Jeremy. So I think a bit similar to what you're describing. So there is a movement. There are specialists, neurologists, particularly them, and also patient organizations demanding recognition and sort of an end to this kind of epistemic injustice, to borrow that term. But it's something that women, in particular, are still experiencing. But they're also setting up sort of outpatient clinics for long COVID patients. And there was an interesting thing last week where they were going to set up an outpatient clinic at the university hospital here in Vienna, and it was supposed to be sort of attached to the psychiatric ward or psychiatric clinic. And then there's sort of a discussion, sort of boundary work between disciplines saying, well, this is not psychiatric, it's not mental, it's not mental health care, it's neurological or it's internal medicine. So the status, the kind of epistemic status of long COVID is sort of in negotiation still in Austria. And I think that is really fascinating. But I think there's sort of a consensus in public discourse that it's a thing. It's very minimal, but it's definitely, there's sort of no debate that it isn't a thing, except for those who, are, very skeptical of all these things to begin with. But
I'm just saying goodbye to the person who's leaving.
yeah. But it's something, so Nora and I will actually be using this example also with for teaching shortly, right? So long COVID patient, social movements. Nora, let's have students research the status of the movement.
Yeah, definitely. And I think in Austria, it's still kind of gaining the momentum of being recognized at some point. So it's really just an issue of, activism and some beginning of institutionalization, but it's very grassroots right now.
Yeah.
Yes, I think Pierre could talk about it more than me. But in France, we have a kind of denial regarding long COVID, including from health professionals.
Really?
Absolutely, yes. This
Okay.
is very shocking fact because an evaluation from the Public Health France has shown that in France there are 2 million people with long COVID. Among them, there are 600,000 people with severe long COVID.
Mm.
And we have made a lot of qualitative interviews of health professionals, social healthcare, social professionals, and also patients, naturally. And which is absolutely shocking is that there is a consensus between patients and the professionals who accepted to participate in the qualitative interviews, showing that there is a denial of the problem. When there is not a denial, there is a minimization, which is not far from denial, in fact, this minimization discourse, including at the institutional level, regional and national. And also there is a lot of, when we tried to have GPs accepting participating in an interview, a qualitative interview, regarding how they dealt with people with this disease or this syndrome, they tried to escape. They didn't accept to participate in an interview. They were not at ease with this with this question, and they behaved as with us, as with patients. They try to escape, to take responsibility of caring with these people. A lot of them. It is incredible. And I was just, when you were answering the question of Jeremy, you work on the idea, which is particularly interesting indeed, of valuing how different kind of peoples or stakeholders value vaccines. And I think it would be interesting regarding long COVID to work on how people devalue this disease, and among whom there is also scientists.
Yeah.
This is incredible. We have an emerging new disease or new syndrome, and one of the most striking reaction is to try to avoid it, rather to cope with it, rather to face it, rather to invest to better understand what is happening, rather to try to understand what are the mechanisms by which the people with long COVID not only suffer from long COVID, but also they suffer from social I don't find the term.
Isolation, right?
There are great social consequences of this syndrome and disease. This is a subject of research. This is a subject for the citizens. This is a subject for a society, and especially a society with a rich society, a Western country. And the reaction is to put it on the side, in fact. Mainly, naturally, there are people who deal with it. There are healthcare professionals who are particularly invested in welcoming these people. But this has been, for them, a very difficult issue because patients know these healthcare professionals, and these healthcare professionals are overwhelmed. And there are many holes in the networks, the healthcare networks in France, or territories, to be more clear in my sentence, territories in which there is nothing prepared and organized for these patients. Nothing.
Yeah, I think that's
This is my comment.
Yeah, this is very, I think it's very relatable. Also in Austria, there are regions where there is no coverage at all. There is no assistance for people at all. It's a bit easier in the city with large doctors' offices. And like you were saying, Pierre, also here, individual doctors taking care of basically long COVID patients only, just specializing in them, because this is where people can go. So the hope is really that there is more outpatient clinics and some inpatient care when necessary that they're trying to set up. But the problem is, I think for some time, people were actually valuing the COVID vaccine in terms of preventing long COVID. When this became sort of more visible and sort of more out in the open in public discourse in the media, people were like, oh yeah, I want to avoid long COVID, so I'm going to get vaccinated, or frankly, also in children, so avoiding long COVID in children, or helping avoid it by, getting them vaccinated. So things that have also gone through my mind, I will, admit it. And I think people have a very hard, and certainly doctors have a hard time changing the ways of doing things. And long COVID calls into question something that was also denied for decades, which is, this ME and chronic fatigue syndrome and post-viral infection issues. And there was always kind of, people already blocking that out, denying it, and denying, also patients' rights to help and to care. Causing a lot of social costs, economic costs, whatever you want to call, however you want to value, this condition, it's terrible. And I think calling into question everything that was done in the past, 2 decades, 3 decades on ME and CFS, also now is raised by long COVID, because that means we have to change a lot of other things as well. And healthcare systems and medical education are institutions that are very full of stakeholder interests and, very institutionalized and very difficult to change. So I think, again, much like in other, in rare diseases, it's really up to patient movements to push for this. But in this case, it's patients, who are not able to do this kind of lobbying work even, most of the time. So it's it's terrible, and it's similar here, I think. And I wonder is it better in other countries, you feel? Is there more recognition in other countries? Have you do you know anything about the US, maybe, where there's more patient movements? I mean, now probably is not the time to ask that question, but
I don't know, frankly. We had no time to, but I think there is more concern, for example, in the UK or also in Germany regarding these people, these patients.
Yeah, and more and
better care too. So
yeah, and patient organizations, right? So patient organizations have more of an institutional role actually in the UK healthcare system. That's part of it maybe, but yeah, it's something I think to look out for in the current in the COVID policy evaluations, in these inquiries that are going on in the UK, in other countries, in Germany, where they're also assessing that the consequences of failed vaccination programs or testing programs, etc. So it's maybe something to look out for, whether that is being problematized in these policy evaluations that are going on still. Yeah.
Laura, you raised your hand.
Yeah, thank you. I just wanted to add because another group that is heavily affected with long COVID is also educators. And we also did an interview series with kindergarten educators, and there the issue of long COVID was brought up by my interview participants in the regard of how do we deal with our colleagues who have long COVID, who are not able to work anymore, but have no funds they can kind of draw on. Can't go to pension, right? So there was this very like everyday dealing with person that is not able to work anymore, but it's heavily informalized at the same time. So that was a very interesting aspect, also the navigation of how do we deal with these people, what to do. And there is no, as I said before, no kind of institutionalized way to go at this point. So it's all very
Absolutely.
individualized and fragmented. And yeah, we hope that there will be some kind of outpatient clinic soon for these long COVID patients.
Okay. Should we stop on this depressing subject of the long COVID? You know, I don't know if it exists in Austria, but in France we have a controversy regarding the Lyme disease. With the chronic Lyme disease, which is not considered as a disease by many health professionals. And at least two years ago, the long COVID was frequently compared to the chronic Lyme disease by many public health experts,
Really? Oh,
suggesting
wow.
that long COVID may be a kind of fake disease, at least in many situations.
Wow. Wow, that's fascinating. Okay. I've not seen that. I've not heard anyone make that connection here.
Okay, so again, thank you very much, Katharina, Nora, and Dimitri.
So, thank you. This was really enjoyable. Thanks so much for discussing also and raising questions, making us think about other things, and for your enthusiasm. This was very kind and friendly setting.